Hey everyone, welcome to the Emrads video series. I'm Eric Steinberg, an emergency medicine resident in New York City.
And I'm Mustafa Syed, a radiology resident in New York City.
So we designed Emrads to help you, the emergency provider, recognize and treat the most important findings on the x-rays and CTs that we come across every day.
In under 20 minutes, we will go over the essential reading techniques and clinical pearls you need to maximize the care of your patients.
Alright, let's get started. Alright, our first case is a 55-year-old male with a chief complaint of cough times 2 days. As we all know, the differential diagnosis is the meat of emergency medicine, and we love meat. So, right off the bat, how many differentials can you think of for cough?
I'm pretty sure I sat next to this dude on the subway. Thank God I'm in radiology.
Here's a quick differential, courtesy of Emrads Basics of Emergency Medicine. Let's go through it briefly. Obviously, our main concern with any patient with a cough is pneumonia, characterized by fever and sputum production. Your sinusitis patient will have rhinorrhea and sinus tenderness. That we treat with nasal spray, Sudafed, and antibiotics, especially if the symptoms are more than 7 days. We see foreign bodies in every possible orifice here in Manhattan, so always consider it, especially in your pediatric patient with a choking episode. Bronchoscopy is both the diagnostic and treatment modality of choice for foreign body. Asthma, or COPD, can present with cough as well. Although this may be more of a chronic issue, it's been shown that COPD exacerbations may benefit from a Z-Pack. How about that patient that walked 30 blocks and waited 3 hours for his or her upper respiratory infection? Send them home. Same thing for allergic rhinitis, but you can give them hospital-quality Benadryl. Don't forget about GERD, which is worse with lying down and relieved by the GI cocktail. And finally, ACE inhibitors are a fairly common cause of cough, and these patients should be followed up by their PMD and started on an angiotensin receptor blocker or some other hypertension med. So now that we went through all of the possibilities, let's finally take a look at some images.
The chest radiograph is the most common study you'll encounter in the ED. This is not a lecture dedicated to interpretation of the chest radiograph. We will go over the basic findings of pneumonia and some patterns you should look for. Here are the radiographic pearls for approaching pneumonia on a chest radiograph. These include the presence of the silhouette sign, bulging or retraction of the fissures, visibility of the diaphragms, or the presence of air bronchograms.
Where's the pneumonia in this one, man?
As the title says, this is as normal as a chest x-ray can be.
Go on.
On the PA view, this left view is a PA view, the lungs are clear. The costophrenic angles are sharp, and you can clearly see the border of the heart, the trachea, and the diaphragms. Moving on to the lateral, this can be a very confusing area, so keep the basics in mind. There are 3 spaces that should be clear: the retrosternal clear space, the clear space posterior to the heart, overlying the spine, and the retrotracheal triangle, up here. These spaces will become important as we talk about the pathology. Remember that the lateral is used to figure out whether things are anterior or posterior, and the PA is used to figure out whether they're medial or lateral. This is a basic diagram pointing out some of the landmarks you'll be looking for. On the PA, you'll want to pay attention to the minor fissure, the border of the right diaphragm, the border of the right heart, the right paratracheal border, and on the left side, pay attention to the left heart border and the border of the left diaphragm.
I'm starting to sense a theme here, Moose. Pay attention to anatomical borders.
Right. Notice on the lateral, which part of the lung touches what? This is the basis of the silhouette sign. The upper lobe and middle lobes on the right and the upper lobe on the left are separated from the lower lobes by the major oblique fissure. The middle lobe is separated from the right upper lobe by the minor fissure. Notice that the heart contacts the left upper lobe, specifically the lingular portion, and the right middle lobe. Notice that the lower lobes make the most contact with the diaphragms. Also notice that there aren't many structures posterior to the heart. You have some lung, you have the aorta, you have the spine, and you have the esophagus. This is why this area should be clear. This is just to briefly show you the mediastinal divisions. Anterior mediastinum, middle mediastinum, containing the heart, the ascending aorta, the trachea and the hilum, and everything else in the posterior mediastinum. Now on to the exciting part.
Ooh, I see some schmutz on this x-ray.
You got it. Look at the PA. It's obvious there's an opacity in the left thorax. How do you know if it's anterior or posterior? Well, look at the left heart border. You can't see it anymore. This is called silhouetting. The reason you normally see the heart border is because the heart's soft tissue density interfaces sharply with air-filled lung, which is much less dense. If you put something of similar density next to the border, you won't see that border anymore. This should clue you into the fact that this is a left upper lobe pneumonia, specifically lingular. Look at the lateral. This becomes obvious. You see a wedge-shaped opacity overlying the heart, and it's got a slight bulge to it. This is because pneumonia is a space-occupying process. It pushes the fissure out.
Great. So we're using the PA to detect the missing heart border, and we're using the lateral to notice that this is an anterior process with a bulging major fissure. So it's got to be lingular.
Exactly. Let's move on. Use what we've learned so far. Here we have an opacity on the right. It's not really silhouetting anything, so that doesn't help as much. But look at the bottom of the opacity. Lung consolidations usually are not well defined unless something forces it to be. In this case, the minor fissure is outlining it. This means it is most likely the right upper lobe. Looking at the lateral, you see a nice outline of the minor fissure and the major fissure, and you can't see the retrotracheal space clearly because the opacity is projecting over it. So this is a right upper lobe pneumonia.
Again, this goes back to your 4 basic pearls. We don't see anything silhouetting here, but we do see bulging of the fissure on both the PA and lateral, which provide us with distinct anatomical landmarks. Again, we see badness on the superior portion of the lateral, so it must be right upper lobe. I don't know, at first glimpse, I don't see too much here, Moose. But I do see 3 arrows.
The positive arrow sign. Yeah, this is a little trickier. Can you spot the opacity? It's behind the heart. This is a common place to miss an opacity. Notice how the left heart border is preserved. This is a clue that, unlike the previous example, this is not an upper lobe opacity. You also lose the left diaphragm border because it's silhouetted. If you look on the lateral, you see opacification of the area we said should always be clear. This is what we call a positive spine sign. You see this area right here, this wedge shape and opacified, and now you know this is a left lower lobe pneumonia.
Well, I still think this could be easily missed, but as long as we continue with the same approach, we won't miss it. Simply put, the diaphragm silhouettes out, and the heart doesn't. It shouldn't be anything other than left lower lobe pneumonia. The lateral again helps us, showing badness around the spine.
The opacity is pretty obvious here. Right lung. But what lobe? You don't see a nice sharp border, but what you do see is a loss of a right heart border, with preservation of the right diaphragm border. Look at the lateral. You see a nicely outlined, wedge-shaped opacity, which is contained by the right major fissure. This is a classic right middle lobe pneumonia.
Now, not to beat a dead horse here, but the same rules apply. Sweet, let's keep on moving. So let's take what we have learned so far and localize this pneumonia. Where's the badness, everybody?
Again, there is a hazy opacity right here in the lower right lung. It could be right upper lobe, it could be right middle lobe. But go back to the basics. Do you see a fissure? No, so that doesn't help as much. Do you see a silhouette sign? Yes. The right diaphragm border is lost. Additionally, the right heart border is preserved. Look at the lateral to clinch your diagnosis. Here you have a positive spine sign. This is a right lower lobe pneumonia. Last but not least, we often hear the term air bronchogram. This is a form of silhouette sign, if you will. Normally, bronchi are barely visible because they are air-filled structures surrounded by air-filled tissue. When you have consolidation, all the lung tissue, the alveoli, opacifies. This colors in the lungs. Since the bronchi remain air-filled, you have this opacified tissue outlining these air-filled tubes. And this is called an air bronchogram. You see the circular oblong lucencies in the opacity? These are the air bronchograms.
Did you just say oblong? Really? Oblong? Such a radiology word. Oblong.
Now remember, just because there is an opacity doesn't mean it's pneumonia. This is where clinical history and clinical intuition make all the difference. Say someone took a hit to the left side of their chest. That area could be opacified, but it would be due to blood or due to contusion, like parenchymal bleeding. A very large cancer or an airway obstruction can opacify a portion of the lung as well.
Lung collapse, like intubating a single mainstem bronchus, something us ER residents never do, can opacify only one side. Also, edema, both cardiogenic and non-cardiogenic, can result in opacification, although, as we know, these are usually bilateral.
So quick pointers. On the lateral view, if you see a wedge-shaped opacity over the heart, it's going to be a lingular or right middle lobe opacity. If you see loss of the clear space overlying the spine, it's a lower lobe opacity. Diaphragms don't always have to silhouette in lower lobe opacities. This is because some portions of the lower lobe don't touch the diaphragm. The lateral will help you. If your costophrenic angles are not sharp, you have an effusion on your hands.
Wow, that sure makes reading a pneumonia chest x-ray much, much easier. But we all know that all pneumonias are not treated equally. An important question that always comes up is, what counts for healthcare-associated pneumonia? So let's hit this topic. When we use the term HCAP, or healthcare-associated pneumonia, our real concern is identifying the people who are at high risk for multi-drug resistant pneumonia. These are your patients who are hospitalized for more than 2 days within the past 90 days, patients with known antibiotic resistance, your patients who have a family member with a known multi-drug resistant pathogen, your nursing home residents, your patients who are on home infusion therapy, patients with immunosuppressive disease, and of course, the very common hemodialysis patient.
And patients who don't wash their hands.
That's everyone. So you want to keep these people in mind when choosing what antibiotics to use. And here are the Emra Antibiotics Guide recommendations for the treatment of pneumonia. For bread and butter community-acquired pneumonia in a healthy patient, that means no comorbidities, prescribe your patient a Z-Pak, Biaxin, or Doxy. For those with comorbidities, outpatient management should be treated with a respiratory fluoroquinolone, such as levofloxacin or moxifloxacin. And for inpatient treatment of community-acquired pneumonia, ceftriaxone and azithromycin are your go-to antibiotics. For healthcare-associated pneumonia / multi-drug-resistant pneumonia, not 1, not 2, but 3 drugs are recommended. Cefepime or Zosyn for gram-positive, gram-negative, and Pseudomonas coverage, a fluoroquinolone for additional Pseudomonas coverage, and vancomycin for your MRSA coverage. Now, the awesome ER physician is 2 great things. Other than being ridiculously good-looking,
Okay.
he or she is an excellent diagnostician and a keen risk stratifier. Evidence-based clinical decision rules such as PORT, PSI, and CURB are excellent tools to predict potential mortality and disposition for your patients who you have diagnosed with pneumonia. Now, I personally use CURB because it's shorter, it's based on common sense, and the results were quite impressive. An answer of yes to any of their questions counts as 1 point. So when asking all the questions, 0 or 1 point predicted 0.6 and 2.7% 30-day mortality respectively, which is defined as low risk. Simply put, 0 or 1 point, low risk, and you can consider these patients for outpatient management. 2 points is borderline outpatient or inpatient management, as these patients had up to a 7% 30-day mortality. I'll tell you right off the bat, I'm admitting 100% of those. 3 points is considered severe, as these patients have a 14% 30-day mortality. You're admitting all of those. 4 to 5 points is the highest risk group with a 28% 30-day mortality. For these patients, you may want to consider calling the ICU. Now, if you have easy access to different databases such as MDCalc or MedCalc, by all means, feel free to also use the port to guide your management. But if you're going to take one thing home, this is my opinion. Both of these rules ask 4 basic questions. 1. Is your patient old? According to Port, just being 75 alone, without any complaints, already predicts up to a 3% 30-day mortality. Number 2. Do they have comorbidities, such as diabetes? 3. Any abnormal vital signs? I don't care what they are any of them abnormal? 4. Any abnormal labs? Now, if you combine these 2 studies, if you answer yes to any of these 2 questions, the mortality risk is high enough to reflexively admit the patient. So again, old, comorbidities, concerning vitals, concerning labs.
Solid thought process. I just thought you guys admitted anyone over the age of 40.
Next. Now let's quickly review the main topics we went over today. For pneumonia, most important thing, look at those borders. The heart, the diaphragm, and the fissures, the anatomical borders will help you localize where the badness is occurring. It's important to know what counts as healthcare-associated pneumonia. Why? Because we're treating multi-drug resistant pathogens. Not 1, not 2, but 3 antibiotics are recommended for treatment of this patient population. The PSI score, the CURB score, they provide us with evidence-based mortality risks to help us make the right disposition for our patients.
Thank you for listening to us. We hope it wasn't too painful.
Now, this was our first video, and we hope to make many, many more. So please, please, please leave us your feedback. Shoot us an email at emradsnyc, that's EMRADS NYC, at any time, and we'll try to get back to you.
Stay tuned for our next episode when we show you how to save yourself the embarrassment of missing an appendicitis on CT.
That never happens.
Are you not entertained? Are you not entertained?